and at least one gene causing the CHARGE syndrome has been discovered. The letters CHARGE stand for coloboma of the eye, heart defects, atresia of the cornea, restriction, growth and development, and ear abnormalities, including deafness. These features are no longer the only factors in the diagnosis, but we're keeping the name. We love it. We love to charge on. So today, my friends will share part of their story, and then I'll wrap up to help you identify some of the barriers that our families face in meeting their 1, 3, and 6 benchmarks.
I'm Iris Filkins, and I'm one of the Colorado State liaisons for the CHARGE Syndrome Foundation. And this is my family. My husband Kyle and I are local to the Denver area. We're about 20 minutes west of here in Arvada. And this is my daughter Remy. So this is her sign name, Remy. We also like to call her Remy Rue. And so Remy will be 3 years old next month, and she has bilateral cochlear implants and loves Sesame Street. So to get us started, because our family is learning ASL, I thought it'd be fun to teach you a couple signs from Sesame Street. So if you do the letter E at your nose, that's Elmo for his big orange nose. We could do Big Bird, and then Cookie Monster. Cookie Monster. So those are some of Remy's favorite signs right now. She is currently using about 50 to 60 expressive signs. Obviously, some days are better than others, but she is picking up ASL. With her cochlear implants, we're still not quite sure what she can hear, but she wears them every day with her glasses, and we're hopeful that soon she'll realize that sound does in fact have meaning. Remy also attends a toddler program here in Denver at the Anchor Center for Blind Children. They have a very inclusive program that we were able to incorporate ASL into, using Remy's community intervener for deaf-blind children. And we're planning for her to attend preschool in the fall, and so we're just now starting the IEP process and trying to figure out what accommodations and resources Remy will need for school since she is deaf-blind. So that leads me into Remy's medical journey. Remy has been a warrior since day one. She was born at 34 weeks. My pregnancy was very normal, but had extra amniotic fluid that triggered an early labor and an emergency C-section. Remy was in the NICU for 7 weeks, and it echoes a lot of Kate's story. She had 3 surgeries during those 7 weeks, and what felt like diagnosis after diagnosis. It was the shock of a lifetime and a darkness that I don't think I could even begin to explain right now. Kate did a great job. She's come very far, and I thought she did a great job because it was a shock of a lifetime, and we were not only learning a lot about Remy at that time, but also ourselves and the medical field and everything that a CPA knows nothing about. I prefer to be in spreadsheets, so this was definitely an adjustment for us. So that leads me into her diagnosis. Remy was diagnosed with CHARGE syndrome at 1 week old. She has a lot of the classic characteristics of CHARGE syndrome, including bilateral colobomas of her retina and optic nerve. She has microphthalmia of her right eye. She had choanal atresia, which was a complete blockage in her nasal passage. So that was her first surgery at 5 days old. She also has internal and external ear abnormalities, cranial nerve differences, a malrotation in her intestines. So that was her second surgery at 6 days old. So right after the choanal atresia, she had an emergency surgery the next day. And then silent aspiration was detected in the NICU, resulting in her getting into G-tube. So those were her first 3 surgeries in less than 6 weeks of life. And then leading more into her hearing loss diagnosis, a lot of the life-threatening areas of the choanal atresia and the malrotation, those were priority number one when we were transferred. But to get there, we had to be transferred to a level 4 NICU because Remy was born in a small hospital in northern Denver, and they just weren't equipped to handle what they were seeing with Remy. Similar story where she was taken to the NICU. We got general information, but they had no answers for us. So when Remy was 2 days old, she was transferred to Rocky Mountain Hospital for Children. And they did 2 rounds of CT and MRI imaging to learn a little bit more about Remy's anatomy. Originally, they were trying to get images of Remy's nasal passage because they couldn't get that NG tube down. But in that process, they were also trying to see her middle and inner ear, her auditory nerve, and really anything we could get a sense of. Unfortunately, they did not see an auditory nerve in the imaging, but they were able to confirm that Remy had malformed cochleas and missing semicircular canals, which are very common with Charge syndrome. So after that imaging, Remy was referred for a sleeping ABR, which is the auditory brainstem response test, both in the NICU and also outpatient. The ABR results were mixed though. She had 3 sleeping ABRs done, and we originally thought that Remy had moderate and moderate to severe hearing loss. So she started using hearing aids at 3 months old, but we never saw a response, like ever. And it's easy to say that a child is young and close to a newborn and isn't responding and they don't know sound has meaning. But when she was 6 months old, we decided to get ear tubes to try and drain fluid and see if that would help improve her hearing. And at that time, a sedated ABR was done, and we found out that Remy's level of hearing loss was much more significant than we originally thought. And so the conversation switched from using hearing aids to cochlear implants. But Remy is obviously a very complex little girl, and that applies to her ear anatomy as well. And so we had to consult with a few surgeons to find that right team for Remy. And that included both Dr. Lupo at Rocky Mountain Ear Center to be her cochlear implant surgeon, and then also Dr. Mitchell at Rocky Mountain Pediatric ENT to be there to evaluate her narrow airway, to intubate her, to be there for added support, because with Charge syndrome, it's never just one thing. There are 10 to 20 things that we're considering, and a sedation is never easy. And so both surgeons were present for both of her cochlear implant surgeries, which was at 13 months old for her right side, and then 21 months old on her left side. So with all of that, Remy has had both cochlear implants for over a year now, and our communication approach is still primarily sign language. We get ASL lessons through early intervention with our county, and Remy also has a community intervener for deafblind children that help us when we're out and about. We're also using spoken language with Remy, and we narrate everything that we can for her, but we're still not sure what speech she can hear. There are definitely sounds in the higher frequencies, like rattles or musical instruments, or maybe her feeding pump beeping when it's done, that Remy can hear, and it is repeatable. But she's not using spoken language, and so we're still focused on ASL, and we also realize the limitations of technology, and that sometimes the CIs fail, and that she's gonna need language even without those devices. In the very beginning, we were also very focused on touch cues. In the NICU, we were told that Remy was deafblind. We knew that she had impairments in both that were going to make it to where she had a dual sensory loss. And in the NICU as a parent, like, that's terrifying. I don't know any other deafblind people in my regular life. There's obviously like a few stories that you hear. So we wanted Remy to have positive touch. I'm an accountant, hospitals are scary, and we wanted her to know like our touch. So we did touch cues. If they were gonna come in to do anything with her nose, we would tap not only one nostril, but 2 if they were coming in for like a second swab or a second saline, or we would touch her eyes or they were gonna take a lead off, I'd rub and I would sign sorry, and they would take it off just so she kind of had that. So I guess that puts us in the total communication realm for Remy. We want her to have access to language no matter what that language looks like, and so we're also trialing AAC devices to see what works with for Remy, but it is a lot, and sometimes you just want to communicate with your child and not think about 5 different ways of doing it. And so the AAC device is new, but just like everything else, we're trying to figure it out for her. And if I could go back, what is one thing I would tell myself? First, I would tell myself to stay strong, and that you'll find the strength even if you don't think you will. But secondly is to connect with other medical parents. Those connections are both on a personal level, but also a knowledge sharing and resource sharing level. Making those connections will be crucial for navigating this unexpected journey, because parents know this life better than any professional can. I'm so happy that people are attending this session to get a different perspective or to make a connection with a parent, because parents are the ones that know this world inside and out. They're the ones who know all of the tips and tricks, like what headbands to get on Etsy, or what pilot caps worked for their babies, or tips for keeping the magnet of the CI on. When Remy got activated, her audiologist, Allison Beaver, told us, these are gonna fall off 100 times a day, but I want you to put them on 101 times. And I thought to myself, there's no way, this has to be an exaggeration, 100 times, how are we gonna do all of this? And sure enough, Remy's CI app tracks the number of coil offs, and she was averaging close to 200 times a day in the very beginning. But another mom recommended a headband on Etsy, which led me to these really cool plastic pieces that I attached to Remy's glasses. And now that's one less accessory we have to manage, and her processor wearing time increased significantly. Those are the cool things that parents are not only creating for their kiddos, but sharing with other medical parents. So that would be my one piece of advice for myself, but also what I share with new parents that I meet today. And I just, want to thank you for letting me share Remy's story, and now I'll let Stacy tell you theirs.
Okay, I'm Stacy Petralba. I'm an audiologist and the mother of 4-year-old Addison and 2-year-old Benjamin, who was born with Charge syndrome. My family and I live in Las Vegas. This is my son Benjamin. He will be 3 years old in May. He currently gets around by crawling or in his gait trainer. He's 100% tube fed. He's never done oral feeds. He wears a hearing aid in the right ear and a cochlear implant in his left ear. He communicates by vocalizations and signs. He has about 20 to 30 words that he says or signs. He really enjoys reading books. Brown Bear and Chicka Chicka Boom Boom are his current favorites. And he would be the happiest person in the world if he could just sit in your lap and rock himself back and forth all day. So Benjamin was full term at 38 weeks. We didn't know anything was wrong before he was born. It was a typical, uncomplicated pregnancy. I did have extra fluid, but my doctor wasn't really concerned about it. I went into labor spontaneously, and he quickly made his debut. After Benjamin was born, the nurses became concerned pretty quickly. He would pink up when he was crying, but if he wasn't crying, he was turning blue. So they immediately were suspecting choanal atresia, and his was in both nasal passages, so he wasn't getting any air at all, unless he was crying. So he was taken to the NICU right away, and 2 hours later they came back to the room and informed us they had to intubate him to stabilize his airway, and there was a whole list of things that they had found, including severe and life-threatening heart deficits, choanal atresia, abnormal ear shape, and some other things that I don't really remember. He was then transferred to a different hospital where the children's cardiac program is, and the next week was spent getting to know Benjamin, which really just means doing a bunch of tests, all of which found more things wrong with him. So after a few days of this, I just wanted to tell them to stop doing tests. We have enough diagnoses, we don't need any more. We found out about kidney abnormalities. He had a brain bleed. He had colobomas of both eyes, on the optic disc, etc. And we've added more along the way. After an open heart surgery, he was transferred out of state to Primary Children's Hospital in Salt Lake City for his choanal atresia repair because there wasn't anyone in Las Vegas who was able to do that. So Benjamin, we heard the term charge like the day he was born. They pretty much immediately were suspecting charge because he has like all the major diagnostic criteria. And I think what really points physicians to charge is the combination of choanal atresia and colobomas, because those two, occurring together is pretty rare, so usually it means charge. And it was helpful to have that diagnosis so we knew what we were dealing with and to help us find resources. And later on that was confirmed with the CHD7 mutation with genetics. All right, so the hearing loss diagnosis. Benjamin had his hearing test per my request at Primary Children's Hospital while we were waiting for his choanal atresia surgery. He never actually failed a screening because they were suspecting charge. They just went to do a diagnostic ABR right away. So he was about 3 weeks old when he had his hearing test. And by that time I had done my research on charge. I pretty much knew they were going to find some hearing loss. And really I was just hoping that he had an auditory nerve because that would mean we could at least do cochlear implants. So when I found out the hearing loss in his right ear was in the mild to moderate range, I was actually pretty excited about that. When we got back to Las Vegas and he was discharged from the hospital, he went on to have ABRs with early intervention and a private practice audiologist, just confirming those results. So choosing a communication approach for Benjamin was not as straightforward as it may have been if he didn't have the additional medical issues. As a principal, I believe in total communication, but in reality, in the first year of life, we didn't really know what was going to work. Benjamin was not very responsive to interaction. Most of our energy went into feeding him and trying to get him to gain weight for his heart surgery. And it wasn't until he had his major heart repair at 9 months old and then another airway surgery at 15 months old that he began to make improvements developmentally and became more interactive and responsive. Early on, I had a really hard time with his vision diagnosis. Initially, we didn't get much information about what his functional vision was like. We were just told that he has colobomas, they're big, and they're covering his optic disc. It wasn't until Benjamin was about 1.5 years old that we were confident that he could see well enough to sign. To this date, we have not received much support from early intervention with introducing sign language. Our speech pathologist with early intervention works on general language stuff, but she doesn't really sign or have much experience with hearing loss. We recently met a semi-retired teacher of the deaf who we are paying privately for tutoring sessions as she has had the most helpful tips for helping Benjamin. So Las Vegas does not have the wonderful resources that these other ladies have experienced. Voice quality was another concern. After Benjamin's major heart surgery at 9 months old, his left vocal cord got paralyzed from the surgery. So for about 2 months, we didn't hear any sound from him. No crying, nothing. It was terrifying. So since then, his voice quality has improved significantly, but at that time, we didn't know if he was going to be able to use his voice. So Benjamin got his hearing aids at 4 months old and his cochlear implant in the left ear at 2.5 years old. There was some delay in getting the cochlear implant due to other surgeries that were more important and due to having to coordinate care out of state because he gets ENT and audiology care in Salt Lake City, so we travel for that. I made the decision to pursue a cochlear implant for his left ear because it was impossible to get his left hearing aid to meet prescriptive targets without feedback. And I just didn't feel like he was getting much access to high frequency information without an implant. So I also felt like a cochlear implant would provide him with more stable access to sound because we wouldn't have to worry about fluctuations in hearing due to middle ear issues that are also common with Charge syndrome. We have struggled a lot with keeping Benjamin's hearing devices on. He'll leave them on if you're holding him or doing something with him, but as soon as you walk away or set him down, they're off and he's chewing on them. So that is a challenge we're still working on. There's a session on that, I think, later today, so I might be going to that. How to keep the devices on. I need all the tricks. So looking back, what is one thing I would tell myself? I would say just don't second guess yourself. Trust your mommy instinct. It's easy to look back and think, well, what if we did this or what if we did that? And I would just say be confident and know what you're doing is best for you and your family.
For me to tell my story, and I take so much joy in watching you develop your own and sharing that with everyone. Thank you so much. This is a short list of some of the reasons why children with CHARG syndrome and other medical complications don't meet their 136 benchmarks. I don't want to read them all, it will take too long. You can look at our slides later. How can the CHARG Syndrome Foundation help? First, we're so excited. We have a full-time outreach director named Lourdes Quintana Baez, and she speaks Spanish. She is the nicest, most wonderful person you will ever meet. If you come across a family that is struggling, she can get you connected to liaisons. We have medical travel assistance for families that need to travel, additional costs that are not covered by insurance, recreational grants for families, tons of information for professionals, including these grant opportunities that are not always claimed all the way, not just for scientific, but for clinical as well. And we invite everyone to come to our conference. It's the best time ever. Family-to-family support matters. Find your state's liaison. We're very close to having a liaison in every state. States that do not have volunteer parents have a regional facilitator that covers their area. State deafblind projects. Would you like to come to conference in 2025? It's going to be a great party. Finally, we invite everyone to come to our walk and roll in May. It's such a good time. It's time for families to get together. It's free to participate, and we'd love to party with you. Thank you so much.